Just a few minutes after 12, so I think we'll go ahead and get started. Welcome. I want to welcome everyone. My name is Dr. Jill Rockbeisel. I'm the chair of psychiatry. I want to welcome all faculty, trainees, and invited guests from other departments and areas. First, I want to say Happy New Year. I hope everyone had a relaxing and peaceful New Year holiday, and all refreshed and getting ready to get our 2024 off to a good start. And I think today we have a particularly good start. Not only do we have a fellow colleague from the Department of Neurology, but we have a celebrity who was on the cover of Baltimore's Top Docs for November. So when you go to the grocery store and you see the magazines, there he is. So it is just, housekeeping. Please make sure your phones are muted. Folks online. And so far, oops, what happened there? Nope. Wait a minute. I don't know what I did there. There we go. Please put your questions in the chat and we'll monitor it. And if there's a question that's particularly critical at that moment, our guest speaker is willing to take questions mid talk, but otherwise we'll take most of the questions at the end. So it is my pleasure to introduce to you today our guest speaker, Dr. David Benavides. He's an assistant professor in the Department of Neurology here in the School of Medicine. Dr. Benavides earned his MD and PhD degrees from the Medical Scientist Training Program at the University of Texas Southwestern Medical Center in Dallas, Texas. As a neuroscientist graduate student, he employed a multidisciplinary approach to study reward signaling, learning and memory, and mood-related behavior. Dr. Benavides completed neurology residency at Hopkins and followed this with a fellowship training in the Division of Neuroimmunology and Neurologic Infections. He has also completed postdoctoral fellowship training in molecular neuroscience at Johns Hopkins. Dr. Benavides directs a preclinical translational clinical neuroscience research program to investigate immune regulation of neuronal function with particular interest in autoimmune encephalitis. The research program uses cell culture, primary neuronal culture, and rodent animal models combined with pharmacology, protein biochemistry, proteomics, cell biology, and molecular biology. The unifying goal of this research program is to identify novel therapeutic targets for neurologic diseases. Dr. Benavides holds board certification from the American Board of Psychiatry and Neurology, is a fellow of the American Academy of Neurology, and is involved in the Maryland Center for Multiple Sclerosis Treatment and Research. So please join me in welcoming Dr. Benavides as he presents an update on autoimmune encephalitis.
Good morning, everyone. Thank you, Dr. Rockbeisel, and thank you for the organizers for the invitation to speak with you today. I'm a very passionate clinician scientist in this field. This patient population motivates my research interests. I see these patients in my outpatient practice, and as Dr. Rockbeisel introduced, this disease constellation really informs the work that we're doing with the intent of expanding our understanding of the biomarkers, diagnostic and prognostic, with the hopes of advancing novel therapeutics to improve patient outcomes in autoimmune encephalitis. Now, today we will discuss off-label use of immunotherapy for autoimmune encephalitis. All of the medications that we use in this condition are used off-label, and I do serve as a site PI for a clinical trial in autoimmune encephalitis. Now, the field of autoimmune encephalitis has been rapidly evolving over the years. These disorders require multidisciplinary care as they present with a wide breadth and constellation of disorders. So it's really critical that many providers across multiple disciplines are familiar with the approach to the diagnosis and management of these disorders. And it's really this that inspires, I think, the appreciation. And I'm really grateful for the opportunity to share my insights and discuss this with you in today's session. So with that, the learning objectives for today's session are to incorporate the latest diagnostic approaches in autoimmune encephalitis, appraise the pathogenic mechanisms by which autoantibody-associated forms of the disease occur, recognize some of the key critical management concepts in the treatment of these disorders, and time permitting, review some of the research techniques that are used to identify those forms of autoimmune encephalitis in which antibodies are participating in the pathogenesis of the disease. I'd like to start the session with a case that was seen here at the University of Maryland. This is a 34-year-old woman that presented with acute psychosis. She initially was admitted to an outside hospital with 2 weeks of progressive behavioral symptoms that were described as grandiosity, paranoia, delusions, and hypervigilance. At the outside facility, she had a metabolic evaluation that was unrevealing. There was no evidence of any toxic exposures, and EKG was normal. The patient was admitted to an inpatient psychiatric ward for further management. And in reviewing the rest of her history, she really had no significant past medical history. There was a report of some occasional drug use, but nothing in the recent past. And delving into her family history, there was a history of autoimmunity in her mother, but otherwise this was a previously healthy, completely independent person. Now, in the inpatient psychiatric ward, the patient had, there we go, ongoing psychosis, mixed agitation and catatonia. She was managed medically with a whole host of medications with varying responses. And during the course of her hospitalization required intermittent restraints and at times locked door seclusion to manage these periods of her behavioral symptoms. Now, 2 weeks into this clinical presentation, she had a generalized tonic-clonic seizure, which was managed medically, required intubation, sedation, and this informed further diagnostic evaluation and treatment. Now, she underwent an MRI of her brain. A section is shown here. This is an axial MRI T2 flare sequence, and it's largely unremarkable. There's no areas of increased T2 signal. There was no contrast enhancement, no areas of, territorial injury. A lumbar puncture was completed, and the spinal fluid results are shown here. Again, no real evidence of neuroinflammation. There's normal white blood cell counts. Proteins are not elevated. There's no evidence of microbial infection, at least by culture or looking for HSV, and no evidence of malignant cells. Her seizures were clinically controlled, and later in her hospitalization, she had an EEG completed that demonstrated a pattern shown here, which is this rhythmic delta slowing that's seen really throughout multiple leads. This is a bipolar montage with left, right shown. And at times, this fast frequency beta is seen riding on top of this delta brush, or otherwise known as a delta brush appearance. Our patient was also noted to have a hyperkinetic movement disorder, although this is not our patient. This video does demonstrate the types of, Dave, I think I might need help. Sure, thanks. So I'm grateful to my colleague, Dr. Rich, who provided this video, which again shows characteristic features, this hyperkinetic orofacial dyskinesia. Now, these movements that we're going to see are not seizures. They do not have, these movements are not seizures. They do not have EEG correlates. They do not respond to anti-seizure medications. These movements, we believe, are the sequelae of dysregulation of pyramidal and extrapyramidal pathways. And you can see there's eyebrow raise, intermittent shrugging, again, the orofacial lingual movements. These can be quite distressing. Patients can chip teeth. chew on ET tubes. It can be distressing to providers and family members involved with their care. The remainder of the patient's diagnostic evaluation included a CT scan of the chest, abdomen, and pelvis, which showed a large adnexal mass and bilateral ovarian cysts. The patient underwent surgery to have these ovarian abnormalities and the mass resected, and pathology showed a mature teratoma, and a confirmatory diagnostic test resulted from her cerebrospinal fluid lab. So with that presentation, any guesses as to what the diagnosis is in this case? Excellent. That's paraneoplastic anti-NMDA receptor encephalitis associated with ovarian teratoma. It's a very classic case. I wanted to start the presentation with it because it illustrates a lot of the key features that we see in the disorder and that I hope to touch on throughout the presentation. But to take a step back, encephalitis is a disease of brain inflammation. And it's a significant public health issue because many patients die of encephalitis, and those that survive their illness are at significant risk for prolonged neurologic disability and morbidity. The etiologies that underlie encephalitis are varied, as is the prognosis and the outcomes. But the causes can include both infectious, non-infectious, and in many cases, idiopathic. Because of these varied etiologies, getting true incidence rates can be challenging, but at least in the US or in developed countries, all-cause encephalitis incidence rates are believed to be between 5 to 10 per 100,000 person years. And as I mentioned, many of the cases of encephalitis end up being of unknown cause, and this is really underlines the appreciation that dysregulation of the immune system is likely underlying these disorders. And the diagnostic approach when encephalitis is clinically suspected really works to identify supportive evidence of neuroinflammation. And that often comes in the form of biomarkers, either serologic in the spinal fluid or MRI features or EEG features that suggest immune dysregulation, inflammation, and dysfunction within nervous tissue. Now, these biomarkers that we're going to spend a lot of time thinking about or talking about today is really going to focus on autoantibodies that target neuroglial antigens. The identification of these types of autoantibodies is a rapidly evolving field. Each year, there's more and more novel antigens, novel clinical syndromes that are being described. And the really unanswered questions revolve around what role systemic immune dysregulation, as well as the compartmentalized intrathecal inflammation that occurs in these diseases, as well as the dysregulation of resident neuroglial cells, including microglia, astrocytes, and myelinating cells like oligodendrocytes. So all of these really are part of this emerging appreciation in the disease, and today's discussion hopefully will include a discussion around multiple modalities of inflammation, but primarily centered on autoantibodies. Now, today's case reviewed anti-NMDA receptor encephalitis. It's the most common form of autoimmune encephalitis. It follows a very well-characterized, well-documented clinical syndrome, which is depicted in the schematic here on the right. Most cases will begin with a viral prodrome, which is described as low-grade fever, malaise, headache. This can be followed quite precipitously by a quite profound onset and neurocognitive decline as a result of neuropsychiatric symptoms, psychosis, language dysfunction, insomnia, sleep disorder, and the emergence of neurologic symptoms, including movement disorders, seizures, dysautonomia, hypoventilation, coma. The challenge is that for those patients that do survive this illness, there can be really profound, prolonged deficits. And this is really the stage of the disease for which there is the greatest unmet need. I think we've gotten better about advancing diagnostics, empirically initiating immunotherapy earlier in the course, which is associated with better outcomes, but we still have not adequately addressed what the chronic sequelae of these disorders are for these patients. And as I mentioned, this disorder is associated with an autoantibody that is believed to be directly pathogenic. The disorder has made its way into, media and the public arena. It's appeared on medical mystery shows. Anti-NMDA receptor encephalitis was the topic of the 2012 New York Times best-selling autobiography by New York Post writer Susanna Cahalan, where she recounts her experience with the disease. And this book was turned into a movie that was released in Netflix back in 2018. So Susanna had a good outcome. Many patients with the disease can have good outcomes, but this disease can be fatal. And it's really the lack of specific therapies for both this and other subtypes of the disorder that inspire the field to basically get better. So autoimmune encephalitis is a very heterogeneous disease, and some of the emerging concepts have centered around identifying classification schema that can be anchored on either anatomical substrates that are dysfunctional in the disorder, the clinical syndrome or the clinical phenotype, right? We know that psychiatric presentations can be the principal presentation of some of these disorders, as can movement disorders, seizure disorders, or new onset refractory status epilepticus is a very common manifestation of autoimmune encephalitis, or combined disorders with multiple neuroanatomic substrates and clinical presentations at play. Etiologic, right? Patients can have this as a post-infectious process, as a process associated with an underlying malignancy. These disorders have been described following immune therapies, such as immune checkpoint inhibitors for cancer or other immune modulating therapies. And as we discussed, many go undiagnosed or unidentified, so they're so-called idiopathic. And historically, much of the field had centered on the identification of autoantibodies in order to aid in the classification of the conformation of these disorders. And these antibodies can target antigens that are inside of cells, put on the cell surface, or exposed antigens. There are cases for which there is no definable autoantibody, so-called seronegative cases. And historically, the diagnosis or the dependence on finding an antibody was really preventing early initiation of immunotherapy, because these antibodies can take weeks to result. So the field really shifted significantly back in 2016 following the publication of clinical recommendations. This was a publication in Lancet Neurology, which has since come to be known as the Grouse criteria. And these now stand as benchmarks in the field and provide practical syndrome-based approaches, as well as multiple levels of clinical evidence, possible, probable, and definite, to make a diagnosis of autoimmune encephalitis in order to inform earlier exposure to immunotherapy and the appropriate escalation if there is failure to respond. So these criteria borrowed heavily from the criteria that have been put forward by the Infectious Disease Society of America. So shown here on the left are the IDSA criteria for encephalitis. These criteria require 24 hours of altered mental status with no alternative cause, and some combination of minor criteria. Two of these criteria get you possible encephalitis, greater than 3 give you probable, and encephalitis can be confirmed if there's brain biopsy, evidence of a pathogenic organism, or the identification of an antibody that's been well associated with the disease. So these minor criteria include fever, generalized seizures not previously attributable to an epileptic disorder, new focal neurologic findings, evidence of inflammation by increased white blood cell count in spinal fluid, an abnormal MRI suggestive of encephalitis, or an abnormal EEG consistent with encephalitis. So in the Grouse criteria that were put forth in 2016, a patient experiencing a subacute onset of a neuropsychiatric syndrome. So this is onset of symptoms within 12 weeks that just has one of these 4 features, which were lifted directly from the encephalitis minor criteria. One of those features meets criteria for possible autoimmune encephalitis. Now, this criteria, reasonable exclusion of alternate causes, is a challenging one, and what constitutes a reasonable workup varies based on who you talk to. But suffice it to say, this is a very low bar in order to consider a possible autoimmune etiology. If you have somebody with a subacute onset of symptoms and one of these features, it would be reasonable to move forward with immunotherapy while pursuing further diagnostic testing. I'll also say it's clinically impossible to distinguish between infectious and non-infectious causes of encephalitis. So patients that are presenting with these kinds of syndromes are often empirically initiated on antimicrobial therapy, antiviral, antibacterial, and antifungal, depending on their immune status. And that sometimes ends up being a challenge, right? Some providers see the challenge of initiating an antimicrobial and an immunosuppressant, but we don't have good evidence to dissuade the use of immunotherapy in the appropriate patients. In fact, there's actually trials and some observational studies that suggest that immunotherapy may actually aid in some very florid viral and other forms of meningoencephalitis from infectious etiologies. So suffice it to say, it's a very low bar, and patients that are presenting with these symptoms should be entertained. The possibility of using immune therapy should be entertained. Now, as the criteria posit, the diagnostic approach is really appropriate appraisal of the clinical syndromes, getting the appropriate paraclinical data, which includes MRI of the brain or other neural axis based on what the symptoms are, an EEG, serologic analysis to evaluate metabolic state, other potential toxic exposures, and a lumbar puncture. And of course, we're reviewing the appropriate differential diagnosis. Now, we reviewed the Grouse criteria for possible autoimmune encephalitis, and that really serves as an entry point. Once that possible autoimmune encephalitis criteria is met, you then enter into the algorithm that is put forth in the Grouse criteria. And the goal here is not to review these in its entirety, but it's just to see that having a diagnosis of possible AE gets you into the algorithm whereby you can then progress to additional criteria, and if met, can transition to either definite or probable autoimmune, and then the role for autoantibody testing can give you a definite or specific subtype. So for instance, if we meet criteria for possible AE, the next step is to evaluate if you meet criteria for limbic encephalitis. So these are the diagnostic criteria for limbic encephalitis. A patient must have all four of the following: that subacute onset, so it's within 12 weeks of onset of the disease; bilateral MRI abnormalities consistent with encephalitis. So this is often mesial temporal lobe, T2 flare hyperintensities, and swelling; at least one feature that's suggestive of CNS inflammation with either increased white blood cells or an EEG with slowing or epileptic discharges; and exclusion of some other toxic metabolic disorder. Now, limbic encephalitis is a very common syndrome. It can be associated with malignancy. It's a so-called high-risk clinical phenotype for paraneoplastic disease. So familiarity with the MRI appearance, right? This T2 hyperintense on this T2 flare axial MRI of the brain in a patient with limbic encephalitis is very classic. These patients often will have seizures, and it's really important to pursue a comprehensive malignancy screen. Been shown here in this slide are other characteristic MRI features with other antibody-associated autoimmune encephalitis. This is a patient that has anti-dopamine 2 receptor antibodies. So you can see the increased T2 signal and swelling within the caudate and putamen bilaterally. Not surprisingly, these patients can have movement disorders and cognitive dysfunction as prominent features. This is a MRI of a patient with anti-NMDA receptor encephalitis. The most common MRI finding in anti-NMDA receptor encephalitis is that it's normal and it's unremarkable. We can at times find some T2 increased signal, but most patients with anti-NMDA receptor encephalitis will have a normal MRI, which is why MRI features aren't part of the diagnostic criteria in anti-NMDA receptor encephalitis. Just to follow up just a few other MRIs that are characteristic for these particular subtypes. So this is a patient that has anti-GABA A receptor encephalitis. Now, this clinically presents with frequent seizures and is defined in its MRI features by these multifocal, both cortical and subcortical MRI abnormalities. The cingulate gyrus is very often involved, and the MRI features have been described to be either confluent or spotted. So these can be kind of signals early on, right? If you get an MRI that looks like this, you can actually kind of potentially ascertain or guess as to what the positive antibody will be. Here in this panel is shown a patient with acute disseminated encephalomyelitis, or ADEM, associated with anti-MOG antibodies. These are myelin oligodendrocyte glycoprotein antibodies. These patients can present with a whole myriad of optic, brain, and spinal cord involvement. And ADEM can be reversible, but MOG antibody-associated disease is another rapidly evolving state, and some of these patients can present with encephalitis, which is why it's included here. And then this is a patient that has anti-AMPA receptor antibodies. This is a glutamate type neurotransmitter receptor. Limbic encephalitis is prominent. Seizures and psychosis are quite prominent in this disorder. And most patients with anti-AMPA receptor encephalitis have an associated malignancy. And this can be a very profound disorder. And then the last case specific case we'll review is anti-GFAP astrocytopathy. So this is a disorder associated with antibodies to GFAP. And I present it to this group because most syndromes will present as a meningoencephalitis, and most of the symptoms associated with the disease will include delirium or psychiatric symptoms. Now, on the MRIs, what we're seeing here, these are all post-contrast T1 weighted images, and these are demonstrating some of the characteristic findings in the MRI. So, shown here are these radially oriented stripes of contrast enhancement that are coming off the ependymal surface. Here we can see leptomeningeal enhancement, as well as this area of nodular enhancement, which can be seen in the disease. This is a case demonstrating these serpiginous or sort of long worm-like areas of contrast enhancement. Here, this patient has some punctate enhancement here again in the subependymal space. And this is a sagittal post-contrast T1 weighted image of the spinal cord, and you can see this punctate periependymal contrast enhancement that can be in the spinal cord. Yes. No. Yeah, the MRI is often normal. At best, with some of these leptomeningeal enhancement, if it's profound, there can be some cortical T2 changes. And likewise, these areas of contrast enhancement are some of these radially oriented, but the contrast enhancement pattern is much more sensitive. Yeah. And again, it would be informed, right? What we scan and where we scan would really be informed by what the clinical syndrome is. But it's an excellent point. Some of these disorders have features that are only observed on contrasted scans. Thank you. So we'll jump back into into the algorithm. We talked about possible and then LE. There are criteria for anti-NMDA receptor encephalitis. And because it's such a well-defined clinical syndrome, the principal criteria are really based around those clinical findings, right? So you need 4 of the major groups of symptoms. So that's, psychiatric or cognitive symptoms, speech dysfunction, seizures, often hyperkinetic movement disorders or rigidity, decreased level of consciousness, or autonomic dysfunction, and at least one feature that suggests inflammation, either an abnormal EEG, it can show slowing, it can show the delta brush pattern that we saw in our case, or it can just have sharps or evidence of seizures, and either increased white blood cells or oligoclonal bands. Oligoclonal bands represent antibodies that are being produced in the intrathecal space, and they're unique and not found in the blood sample. So when we look for oligoclonal bands, we're testing spinal fluid, we're testing blood, and we're looking for antibodies that are in spinal fluid that are not present in blood. So 4 of these kinds of symptoms and 1 feature gets you probable anti-NMDA receptor encephalitis. And you can make the diagnosis of definite anti-NMDA receptor encephalitis if you have 1 of the cardinal clinical symptoms and you identify anti-NMDA antibodies in spinal fluid. So our patient met all of these criteria, had a very classic case. And it's important to appreciate that anti-NMDA receptor encephalitis can be associated with a paraneoplastic disorder, like in the case of our patient, ovarian teratoma. It can also follow neurotropic infection, like HSV encephalitis. There's a well-documented etiology for, recurrent HSV encephalitis, when in fact it's not a new HSV bout of encephalitis, it's a subsequent autoimmune encephalitis that emerged following the viral destruction and injury from the HSV. So far, we've really emphasized the utility of the identification of these autoantibodies, but I do want to illustrate that although we have to look for them, there are criteria to have probable autoimmune encephalitis or so-called seronegative cases. So if you have the same kind of clinical syndrome and a well-defined, autoimmune encephalitis presentation, and you've looked for antibodies in blood and spinal fluid and not found them, you can meet these criteria by having 2 of the following findings. You have an abnormal MRI, you have inflammation in the spinal fluid by any of these criteria, right? Increased cells, increased oligoclonal bands, increased IgG index, which just says there's just more antibodies in that CSF space, or a brain biopsy showing evidence of infiltration of inflammatory cells and excluding other disorders like malignancy or evidence of mitochondrial or genetic disorder. And the reason this is critical is we're often using these diagnostic criteria in parallel with clinical treatment. So if a patient was initiated on immune therapy as you're working your way through the algorithm and is failing to respond, and you're failing to identify additional evidence to support an immune cause, we end up in a challenging equipoise where is the patient not responding because we're not treating the immune system hard enough, or is the patient not responding because it's not immune mediated? And that's really where brain biopsy and further diagnostic testing can be helpful. Question? So the EEG in a patient for whom we're considering this isn't sufficiently strong or suggestive of an immune-mediated etiology, at least not enough to warrant, let's say, escalation or further immune therapy. So these criteria, we would say, are much more stringent, much less, they're much more stringent criteria. And someone meeting probable autoimmune encephalitis criteria, according to this, one could, in good faith, advance immune therapy or potentially move to, everything's off label, but more dangerous therapies because you have documented some evidence that there is immune dysfunction. Correct. It's not specific, and it in and of itself, in the absence of a defined autoantibody, isn't enough. Excellent questions. Thank you. So in general, the diagnostic approach is to really, confirm brain pathology with MRI, EEG, appraisal of the clinical syndrome. And there is a literature that's supporting the use of MRI PET, PET, brain PET to evaluate for metabolism changes in these disorders as well. Confirm the etiology with lumbar puncture, blood tests, and again, brain biopsy if necessary. With this, one can, again, move forward with empiric immunotherapy while screening for an underlying malignancy, because we know those paraneoplastic associated disorders, it's treatment of the underlying malignancy that is most associated with better outcomes and reduced risk of relapse. So we talked a little bit about this, and I want to come back to it as kind of like this mechanism of genesis of autoimmune encephalitis. Following, say, herpes simplex infection, we think that these neurotropic viral infections can lead to damaged neurons, dead cells. This can then release antigens that go to peripheral dendritic cells, are presented to the immune system in an inflammatory, infectious context, and then can lead to the breaking of immune tolerance, expansion of memory B cells, expansion to plasma cells that produce antibodies. And these immune responses, either the antibodies or the antibody producing cells, can make their way back to the central nervous system and set up the kind of immune dysfunction for autoimmune encephalitis. A similar analogous pathogenic mechanism may exist in the setting of underlying malignancy, right? Presumably these cancer cells are expressing CNS antigens, and then when the immune system tries to attack them, those antigens are then exposed to the immune system, and you get the same kind of antibody response in the brain. Now, this type of pathology can occur with both antibodies that occur on the cell surface and in intracellular. And historically, the paraneoplastic associated antibodies tend to be intracellular antigens. These are transcription factors, microtubule, cytoskeletal proteins. And the current thought in the field is the pathophysiology associated with those antibody-associated diseases are really T-cell mediated. That's primarily a T-cell mediated injury, and it's the antibodies serve as like epiphenomena or evidence of immune activation, but the antibodies themselves are probably not directly participating in the pathophysiology of the disease. It's a biomarker you can identify, but in the disease, it's probably not playing an active role. And this is in contrast to those antibodies that are targeting cell surface proteins, like anti-NMDA receptor antibodies. Because these antibodies have the ability to access their antigen in vivo, we believe the antibodies are directly pathogenic, and by directly dysregulating their targets are leading to the disorder. So this is a really key critical concept in the field, and the identification of cell surface antigens, which we believe are directly pathogenic, is a really rapidly evolving field. So this is just a partial list of the current cell surface antibodies or antigen-related syndromes that have been reported, some of which are not yet available for general clinical testing in these clinical panels. But these are all disorders in which we believe elimination of the antibody, elimination of the immune response is going to directly affect patients. And this is, again, in contrast to other locations or localizations for antigens, be them intracellular or at other sites within the neuroaxis or at sites of communication between the nervous system and muscle. Now, these targets are often evaluated in these large autoantibody panels. It is our current recommendation that they be tested in panels because, again, on clinical grounds, they can be very difficult to distinguish, and you're better off looking at a panel that's syndrome or clinical syndrome based in order to have the best likelihood of coming up with something that could be informative for diagnosis and management. The challenge here is that because of these targets being cell surface proteins, the way in which the antigens are presented end up being very critical in their detection. These tests require the proteins be folded in their native state. So this is what leads to the testing taking longer because cells have to be engineered to present these proteins. And then that can then be screened with patient samples, either binding from blood or from spinal fluid. There's also research-based testing in which neurons that are expressing their normal antigens can then be used as substrate. So you wash on spinal fluid from a patient and you can see the antibodies decorating the surface proteins of those neurons grown in culture. And there's also research-based testing in which samples that screen negative for all of the known antigens can be reacted against brain slices in a research lab. And if there's a pattern of staining, shown here in green, that stains the sites of connection between cells, or the so-called neuropil, that may suggest that there's an unidentified cell surface antigen, or if the antibodies stain the cell bodies or the soma, shown here in green where the cell bodies are, that may suggest that it's likely an intracellular antigen. So these are just some important kind of concepts in how we go about, using and interpreting and how this antibody detection is expanding. Question, yes?
The process starts to the peripheral component of this. How blood-based assays don't seem to help?
That's an excellent question. The question's regarding why they're more sensitive coming from the spinal fluid. And it has to do with the fact that we think that the disease is really the product of the intrathecal expansion and antigen-informed maturation. So we may find responses that are in the CSF that are modified from systemic immune responses. So we probably break immune tolerance peripherally, but it expands intrathecally. Immunotherapy is the mainstay of therapy for these disorders, but this is all guided by expert opinion with varied approaches. We have level 4D evidence at best. We use first-line agents, which can include high-dose intravenous steroids, immunoglobulin, or plasmapheresis. In appropriate cases, we can escalate to second-line agents, including B-cell depleting therapies that reduce T-cell function. Some patients are transitioned to chronic immune therapy if they've had relapsing disease or they're having very poor tolerance of some of the other options. And there are case reports on the use of additional medications of varying function, right? Tocilizumab is a anti-IL-6 receptor antibody. Bortezomib inhibits plasma cell function, and anakinra is an IL-1 receptor antagonist. So these have occurred in the literature as case series for refractory disease, but its use is not widely supported because patients that landed in these case series had been exposed to months, if not years, of various other immune therapies. So it's hard to know where the role for these therapies are. Just by way of introduction, I'm sure many providers here have seen patients on these first-line immunotherapies. And these, will often take the form of a course of high-dose steroids, sometimes with an oral taper, the use of intravenous immunoglobulin over the course of about a week, or plasma exchange, again, every other day sessions for about a week. Based on how severe the clinical syndrome is at onset, some of these first-line therapies can be combined. There's no contraindication to using them together, and that approach is generally favored over sequential first-line therapies, right? If you're going to treat somebody, you should treat them hard. And if you're going to make a decision to escalate, it should be within 2 weeks of completion of the first line, right? So waiting months to initiate second line has been associated with poor outcomes and if patients are hit aggressively at onset. Happy to report that there are many clinical trials that are currently enrolling, many of them randomized controlled trials across a number of autoimmune encephalitis subtypes, and using agents of varying mechanism of action. So this is exciting. But the important considerations here are that these drugs are not without significant adverse events and risks. And this really has to be taken in consideration in, considering exposing a patient for whom you're suspecting possible autoimmune encephalitis. And these considerations range from the infectious risks as well as long-standing immune dysregulation or the reactivation of latent infections. So it's the decision to make these medication initiation and treatment changes are not taken lightly. So it's always something to have in mind. In the case of anti-NMDA receptor encephalitis, there have been some studies because it's the most common disorder and there are thousands of cases that have been reported in the literature. There are some features that have been associated with a better outcome. So this is by a modified Rankin score, which is a stroke scale that we use to document independence. So an MRS of 2 indicates that you're able to do everything without any assistance. You can tend to your activities of daily living and settle your affairs without any help. So the literature has generally used MRS of 2 or better to support a good outcome. And young patients and patients that were exposed to immunotherapy early tend to have better outcomes. Poor outcomes, again, MRS is greater than 2, so you need help with something or out to really severely disabled. Some of the things that portend that poor outcome are extremes of age, patients for whom they required an ICU admission during their incident illness, an EEG with extreme delta brush. Again, we're dealing with an NMDA receptor encephalitis cohort. Patients that did not get immunotherapy within 30 days of their symptom onset, and those patients for whom they're getting continued immune therapy 6 months after the onset of their symptoms. So this kind of implies patients that are either being managed chronically with immune therapy are probably not going to do as well. So you're going to see responses early. So that kind of informs the interest in moving aggressively early. And this has also been borne out in the same study looking at, the proportion of patients that had rituximab, right, a second-line agent at their first event. So if they looked at their whole cohort, it was about a third. And if we looked at the patients that had severe disease at onset, even more of those patients were exposed to rituximab early. And over the years, this has been associated with a reduction in the relapse rate amongst just patients that present with the disease. So the practices of early immune therapy escalation to second line are actually being evidenced by reduced relapse rates in these cohorts of patients, right? So early immune therapy leads to better outcomes and reduced relapse rate. The field's getting better about coming up with better scores to document the disability associated with the disease. The MRS scale is a very crude measure. This score, the CASE, which is the clinical assessment scale for autoimmune encephalitis, has been published and now validated. It's 9 different domains, 3 points for each domain, 27-point scale. And in one of the original reports describing the scale can really aid in segregating these patients for whom there's significant disability at onset, but they make rather rapid improvements and their CASE score drop, versus those for whom there's really this like very persistent, very profound disability that is often missed in something as crude as the MRS. Symptom management, long-term recovery are really critical domains that we have to address. This is really where the collaboration and the multidisciplinary care is really critical. Many of our patients have chronic psychiatric symptoms, neurocognitive symptoms that we have to deal with. So both in the acute setting and in their chronic management, as we're managing these symptoms, we have to be mindful of the other symptoms that can be present in the disease. So if we're going to select agents for mood, we have to maybe avoid those that would lower a seizure threshold. If we're going to select agents for seizures or for mood, we want to avoid those that lead to QT prolongation in somebody that's having dysautonomia. We're trying to avoid polypharmacy. We're trying to avoid things that can impair sleep, because these are all the things that we think that are associated with chronic dysfunction in the disease. And as I mentioned before, malignancy screening should be part of not only the initial evaluation, but also should be completed annually, and in some cases more often than annually. It varies in the literature, but in some cases up to 4 years after the incident encephalitis, because these disorders can precede the diagnosis of a malignancy by years. So it's really important that we do that. So in the inpatient setting, we're often doing MRIs. And reproductive organ imaging, so MRIs of the pelvis in pregnant women or in children, pelvic transvaginal ultrasounds, testicular ultrasounds, mammograms, often in the outpatient setting, and we will progress very often to FDG PET, sometimes in the inpatient setting, in order to look for an occult malignancy. I'll touch briefly on misdiagnosis in autoimmune encephalitis. This was a series that was put out by a consortium of multiple autoimmune encephalitis expert sites. So in this case, they had some 25% of the referred cases were misdiagnosed. And of those cases, half of them had functional neurologic disorders. So that's neurologic symptoms and disability that's not referable to an organic cause, or psychiatric diagnoses. So the kinds of things that may lead to a misdiagnosis or may be associated with a misdiagnosis include an insidious onset, right? So this like prolonged chronic disorder without a real clear, real clear clinical syndrome that's often a telltale sign that it's not autoimmune encephalitis. Other medical or medication comorbidities, features on the exam that suggest one of these other things, either, normal testing, other diagnoses, normal brain imaging, normal spinal fluid imaging, or a whole host of serologic markers that can often be overinterpreted. So the field is ripe with a bunch of reports of patients that had a quasi-clinical syndrome and an antibody that tested and it was low positive, or it's been refuted in the literature to not be, clinically important, but these patients are still given immunotherapy labeled as autoimmune encephalitis and referred for expert care because they're not getting better. Well, they're not getting better because it's probably not immune mediated. So these are really places where the field has a lot of, unmet needs and needs to still improve. I'll sort of move forward quickly through this last part. My lab studies NMDA receptor encephalitis. The NMDA receptor is built from a couple of subunits that play critical roles in gating glutamate excitatory neurotransmission. These NMDA receptors play really critical roles in the molecular and cellular pathways that underlie learning and memory, both on the learning long-term depression or weakening and the long-term potentiation or strengthening side. So it's not surprising then that antibodies that would dysregulate NMDA receptor function would lead to the kind of host of neurologic symptoms that the disease does. And some really beautiful work that's been done by Joseph Dalmau's group and many groups since the original description has demonstrated that these antibodies derived from patients can lead to reduction in NMDA receptor content at sites of communication or at synapses. And this can be evidenced both in neurons that are growing in dishes and brain slices, or in animals that you've given antibodies that are derived from patients. So this really stands as the model by which anti-NMDA receptor antibodies cause disease, is by cross-linking and internalizing these NMDA receptors. And this is actually a pretty good model for most of the pathogenesis for these cell surface antibodies. They tend to lead to loss of function or loss of that cell surface antigen. The cells don't die. There's not often an inflammatory infiltrate. You're just kind of removing, with these kind of molecular scissors, that target. Now, my lab is very interested in identifying and characterizing what the molecular consequences of antibody targeting NMDA receptors are from a intracellular signaling and kind of information processing approach using both in vitro and animal model approaches. And we began this work with a very simple hypothesis that the antibodies that are targeting these really critical calcium channels are going to dysregulate a whole host of intracellular signaling cascades. I trained in protein biochemistry. I'm interested in post-translational modifications like protein kinase and protein phosphorylation. So that's really where our lab focused our early efforts. And we combined this with calcium imaging experiments to look at, neural function in response to these antibodies. We use cultures of rodent cells grown and matured to have these, mature synaptic contacts, and the cells that are grown can be really nice platforms to do molecular biology, biochemistry, and pathway analysis. And we've collaborated with colleagues that have cloned antibodies from patients with anti-NMDA receptor encephalitis. And then we're using those antibodies as reagents in our experiments in the lab. So in collaboration with these labs and clones of antibodies, we're able to stain our neurons that are grown in culture and demonstrate that same kind of punctate pattern that has been demonstrated in the field. And then we designed experiments I'll fast forward here, to expose, for instance, neurons that are grown to maturity with these antibodies, and then fractionate parts of the synapse that contain the sites of connection, right? So the so-called synaptosomes, or postsynaptic densities that are enriched for NMDA receptor subunits, or this marker of a synapse, PSD95, and then ask questions about the intracellular signaling using label-free, unbiased phosphoproteomics. So we're subjecting these samples to mass spectrometry, looking for signaling pathways that antibody exposure has dysregulated. And we're happy to say that we identified thousands of phosphopeptides that were differentially regulated in these different treatment conditions. And these peptides belong to hundreds of synaptic proteins that, are involved in many processes that we're really interested in defining. So shown here on the right are, summary of the biologic processes that some of these dysregulated, either increased phosphorylation or decreased phosphorylation, participate in. So we see things like synaptic transmission, postsynaptic structure, synaptic, postsynaptic maturation and regulation. So these are, our lab is actively pursuing and validating and extending these studies so that we can get a better insight into the molecular consequences of the disease. So I'd like to summarize by saying that, these autoantibodies are critical biomarkers. The diagnosis and empiric use of immunotherapy is critical in managing these patients, and we really need to continue the work to identify what the molecular pathophysiology of these antibodies is. I'll thank the members of my lab, both current and past, as well as my mentors and collaborators and funding source. And I'd also like to share that we're launching a new clinical center for autoimmune neurology. This is going to be an opportunity for providers in neurology that are familiar with the diagnosis and management of these disorders to see patients in an outpatient consultative clinic. So we're welcoming referrals of patients that you think may have one of these disorders. We're going to start off by, again, having only a provider referral process, so patients cannot self-refer. So anybody for whom you're suspecting a possible autoimmune etiology, someone who has had an antibody panel tested and there's a positive result, or they're responding in an atypical way to therapy for a psychiatric symptom, we're happy to see them. So beyond the request for referrals, we're also looking to enrich our collaboration and referral process with psychiatry providers, because many of the patients that we're going to see are going to require co-management with psychiatrists and would benefit from your expertise. And for those patients that are referred to us that don't have an autoimmune condition, and as has been evidenced in the literature, many might just have an underlying psychiatric disorder. There's going to be a need for the patients landing somewhere. So again, I thank you for the opportunity to talk with you, and I'm happy to take questions.
So we have two questions from online.
Okay.
Go ahead. Go ahead.
So you had the slide about misdiagnosis for autoimmune encephalitis. I'm wondering about the flip side, right? Like misdiagnosis for psychosis, and thinking about patients that I have with treatment-resistant schizophrenia with some, abnormal appearances or a lot of catatonic symptoms, model the pictures. I don't know if there's been studies about doing these sorts of tests, not within the first 12 weeks, obviously symptoms, but after someone's already been diagnosed as having a psychiatric disorder that isn't responding the way that we want. Is it worth it to still go down this path?
Right. No, it's an excellent question. And I think you identified, I think the real linchpin is regarding the timing. So the literature, and there are proponents that feel very strongly on both sides of the coin. If there are features that suggest neurologic dysfunction, so you're talking about movement disorders, increased falls, increased, motor dysfunction, or tics, or things that might fall on the dyskinesia spectrum in somebody for whom you're not using agents that you would expect those kinds of consequences. I think pursuing testing could be reasonable, but there's a strong literature that argues that schizophrenia is not an autoimmune neurologic condition, but the atypical refractory
Other things. And if somebody already has that label of schizophrenia, then.
So to be clear, when I say going down this route, I mean seeking MRI, EEG, lumbar puncture evidence of inflammation. Because to your point, one wouldn't expect those to be abnormal in a patient with schizophrenia. So if you have an abnormal white cell count or IgG index expansion in someone that has no systemic autoimmunity, that's atypical in that disorder. So
We don't think about what aren't treated, like what that course of illness is longer term.
They don't do well. So the patients that survive are left with very significant chronic disability. And because of the improved awareness and these kinds of criteria, patients are being treated earlier. It is being identified sooner. So the outcomes in general are improving, but even with aggressive management, there are still many patients that do very poorly. And that's really part of the unmet need. I mean, profound refractory seizures, dysautonomia, or maybe negative consequences from the immune therapy that they are being exposed to.
I'll change this.
Sure.
So one thing I suspect about is that I wonder if we don't often catch people with psychiatric symptoms and executive dysfunction and kind of a muddled picture. Maybe we're catching people who are years down in this post.
Exactly.
I just wonder in that case, what do you, because we can have our eyes on people, we don't routinely get contrast, but hey, everyone's got a lot of white matter hyperintensities, you know, so.
So right. I mean, to your point, right, we might have missed the opportunity to treat. We may have missed an opportunity to observe a positive effect from immune therapy. And I think using objective criteria in these cases to inform what is going to serve as evidence of the disease and what is going to serve as evidence of a response to a trial of immune therapy. We shouldn't be adverse to putting patients on trials of therapy so long as we have very, like at the onset, very clear goals as to what we're looking to improve.
There we go. Thank you very much for that talk,
Thank you.
Dr. Benavides. That was fantastic. I want to take the opposite approach. So a month ago, I was asked to review a death from another hospital ED,
Okay.
just as an overview. And I got a team together and somebody that came into the emergency room, mental status changes, aggressive, not responding to any medication, was in 4-point
Restraint.
restraint for 7 days and died. And was not cooperative with anything.
That's
So
good.
didn't have MRIs, EEGs, did get one set of labs that was negative, blood pressure, wasn't any, vital signs were relatively stable, wasn't eating, wasn't drinking. Bizarre case, didn't respond to anything. At what point do you, and a bizarre history as well. So something was missed.
Sure.
And I'm wondering, in case, how often does a reoccurrence occur of that severity if that was in fact the case? And when do you actually treat before you've done a workup?
It's an excellent question. I mean, it's a challenging case, and these unfortunately are not, or they're not rare. So if this patient had no, and I'm always hesitant to give specific recommendations and interpretation, but if a patient had no antecedent psychiatric or neurologic history and presented with this kind of a syndrome and died of unclear etiology, the suspicion is it might have been a missed infectious or non-infectious encephalitis. It's possible. Some of the agitation or catatonia could have been non-convulsive seizures or postictal paralysis that might have been misinterpreted or treated in a different way. The relapse question. So it's possible that this might have been it. Treatment without data is not supported. So we cannot justify the use of immunotherapy without appropriate diagnostic ascertainment because of the risks associated with it and not knowing where to go next. With regard to relapse, again, overall, all comers, the relapse rates have reduced because of treatment approaches, but these can have relapse rates up to 25%. And it's higher in patients that have paraneoplastic associated disease. So if the malignancy is missed or if they have a mild episode of the disease that improves, they can relapse if no one ever looked for an underlying cancer or gave immunotherapy. So those relapse rates, they vary in the literature from 12 to 25%. So it is important to think about.
So we are over time,
Oh,
and I know
thank
we
you.
have 2 more questions online. So we can take those 2 questions. No, this is till 1. So we'll go ahead and take those two questions, but understanding that some people may need to leave.
Sure. And thank you again for the questions. And I see here, the first one is, how worthwhile are blood panels at shotgun search for antibodies when you don't have easy access to quickly obtaining an LP? So again, if you've got someone who meets criteria for possible autoimmune encephalitis and you're progressing down the diagnostic pathway, the highest yield spinal fluid markers and spinal fluid criteria are not absolutely necessary in all of the subsequent criteria, limbic encephalitis, Bickerstaff's, Hashimoto's, right? There are many criteria within the Grouse criteria for specific disorders. So serum antibody testing can play a role, but it can't be the only test. And yeah, I would say follow the algorithm. If you can get blood panels, it's better than not having them, but there should be a plan to expect to advance to spinal fluid analyses because they're more sensitive and they're going to give you a better answer. They're much less likely to give you false positive, low titers of unknown or no clinical significance. But sometimes that's all you can get, and it's in the appropriate patient. It can aid in defining a syndrome, and some of the antibodies in these syndromes can be diagnosed and managed with testing in the serum. Not all of them have this translocation. GAD antibodies, GFAP antibodies, MOG, aquaporin 4, right? These are all better tested in blood than spinal fluid. So thank you. And then Dr. Waltz asked, how often are cases of AE associated with teratomas? We usually trigger sudden immune growth of the teratoma. So for anti-NMDA receptor encephalitis, it's like 40% paraneoplastic, not greater than 90% of which are teratomas. They can occur in men and women. And teratomas are benign tumors, right? Most patients that have them, they're asymptomatic, and most patients with teratomas don't get autoimmune encephalitis. So it remains to be seen how the immune system surveillance and potential clearance of a teratoma participates in the outcomes of the teratoma and the disease. Then the last question here, can you elaborate on TPO antibodies titer and any false positives in AIE? So TPO and thyroglobulin antibodies for the diagnosis of Hashimoto's encephalopathy are very controversial, highly contested. There is no good rule or criteria cutoff that's used. Generally, those that are sky high, we're talking thousands, dilution factors that are thousands, and someone who fits the criteria, one can move forward again using consensus recommendations and treat empirically. And the nice thing is Hashimoto's encephalopathy classically is very steroid responsive. So if you've got somebody that fits the criteria, has a sky high TPO, and you give steroids and they get better, I mean, it's almost diagnostic and therapeutic. If they're not responding to therapy and you go back in and look and it was a borderline result, and they're not getting better, it's probably an irrelevant, erroneous lab, and you're best to keep looking. Thank you again for the questions. Yeah.
Yes, hi, I have a question. Can you hear me okay?
Yes.
This is Deanna Kelly. I'm at the Maryland Psychiatric Research Center. I do a whole line of research looking at gliadin antibodies and gluten sensitivity in people who have psychosis. I have a couple questions. One, I've never seen this, but I'm aware of gluten encephalitis. You didn't mention that today. How frequently is that, and how do you see that? That's one. And the second is that we've done some work looking at the GRIN1 antibody, the subunit of NMDA that is similar in protein structure to the 33-mer fragment of gliadin. So it mimics it in some ways. And we've seen higher rates of this antibody in people who have schizophrenia, especially in our gluten sensitive subgroup. I don't know if you look at GRIN1 antibodies, if they are associated with encephalitis at all. I'm just curious at that. I don't know enough about that. So
sure.
sorry.
Thank you for the questions. And if the antigen that you're talking about is the GRIN1, or GLUN1, GLUN1, that is the subunit that anti-NMDA receptor encephalitis antibodies are associated with. So I'm not aware of the overlap or the incidence with celiac disease, but I think it's a very interesting question. And a gluten sensitivity, sorry, and I may be conflating gluten sensitivity and celiac disease. But we do know that there are subtypes of autoimmune encephalitis that can be associated with systemic autoimmune disorders, including celiac, other gut microbiota dysbiosis. It's a really rapidly evolving field, and I think there's still more unanswered questions. But I presented this from a neurologist perspective, these compartmentalized CSF responsive antibodies, and I think there's still a lot of work to be done to define what biomarkers present in serum may have to do with the diagnosis and prognosis of these disorders.
No, thank you. I'd like to talk to you more about these high rates of these green 1 antibodies that we see in this subgroup of people.
Excellent.
So more about that. Thank you.
I look forward to it. Thank you.
Yeah, thanks.
I was hoping I could ask a question.
When we're finished.
Thank you.
Oh, thank you. Appreciate it. Thank you. Yeah. No, I appreciate it.
Thank you. Thank you much. I'll be in contact. Okay.